This is Matt Schlenker from the University of Toronto, sharing some thoughts on unmet needs in clinical trial design. And I'd really like to thank the organizers for the opportunity to speak on this important topic. Here are my disclosures. So as we think about glaucoma intervention, I think there are a variety of perspectives. And my hope is that the patient is at the center of all thought, evaluation, and ultimately decision-making for new interventions. And I'll just share some views of one of my patients. What would you like in a glaucoma surgery?
I would want to have my pressure lowered to a safe level so I don't have that concern anymore about, is it going to get worse? Is my vision going to be really impaired?
And how about not having to take your glaucoma medications?
And that's a real plus because I didn't do well with the drops.
So from my perspective, patients want to know, 1, are they going blind? 2, will they experience fluctuating vision? And 3, will they have irritation or other side effects? These are the patient considerations, and these should drive our outcomes. Now we have other perspectives, including the regulator. And I would say the role of a regulator is to determine whether the treatment helps and whether it is reasonably safe. And there probably is some room there for some comparative aspect on the safety side. But that is very much the lane of the regulator. It's not the regulator's role, from my perspective, to do comparative efficacy, cost effectiveness, or any clinical decision-making. On the other side, we have the reimburser. There, the role is much more into the relative efficacy, safety, and cost effectiveness versus the other treatment alternatives at that time. And then finally, we have the clinician, and the clinician really needs to put it all together with the patient, again, front and center, grounded in clinical context, looking at the efficacy, which we can hopefully by and large get from RCTs, and also safety, where we'll look at the RCTs, but really we also need to look at observational data to get much broader sample size and understanding. From a clinician side too, on the one hand, I do feel like we have some responsibility for cost prudence, and that's where we align well with the reimburser. On the other side, we have to advocate for our patients when there are new treatments available that are not yet funded and still beneficial for the patient. So as we look at data, there's kind of 3 ways that we can approach the situation, and it kind of depends on what your role is and in what you will do and also what you will look at. So on the regulator side, I think very much this should be a reporting aim. And that's not unlike what our statisticians who help us do. And we want to be very careful to make sure that statisticians help us the reporting, but not in the analysis and not in the interpretation, which is much more relevant in the clinical sense and where clinical expertise should drive what's happening. Our clinical papers, we do have reporting, but we start to get a little bit more in the analysis. Of course, for clinical practice, whether the analysis is perfect, valid, we do have to put a stake in the ground. We do have to make a decision based on what we've seen. And then, of course, the patient, well, they're much more concerned about interpretation. When our key opinion leaders speak, they're often very much in the interpretation space, and our reimbursers. Okay, so let's go back to this concept of having the patient at the center and making sure that the patient's needs and desires are driving our outcomes. And I'm going to summarize the interventional glaucoma literature in one slide. And I sometimes tongue-in-cheek say to trainees that this is really all you need to know about new glaucoma studies and trials. And it's this iconic IOP graph with the intraocular pressure on the y-axis and time on the x-axis with means and either standard errors or standard deviations. And you will find remarkable similarity in the appearance of this graph across medication and glaucoma surgery interventions. And I've written about this and thought a little bit more about this, as again, they almost always appear to be the same. And it's very hard to make decisions when everything kind of looks the same. So here, an editorial that I wrote, how mean intraocular pressures are failing patients. And there's a variety of reasons for that. And I'm just going to touch on some of the most important ones. First is using an average world temperature to decide what to wear. Of course, may seem ridiculous, but that is not unlike what we do in the glaucoma space when we just focus on means. The outcomes of the outliers are the ones we are much, much more concerned. Those are the ones that keep us up at night. Those are the ones where we have significant problems. Also, mean IOP is using an outcome to assess patients instead of patients to assess outcomes. So what does that mean? Well, I'm gonna just look at these on the left and the right side. So using an outcome to assess patients, well, that could be a stats measure, such as a mean, where we really should be using a patient measure. What's important to the patient? What drives our clinical decision making? So for instance, the mean IOP is a stats measure. We see all kinds of means all over the medical literature, whereas we should be looking at the percentage of patients who did well. A p-value is also a very common stats measure, the arbiter of truth, this type 1 error 0.05, when really we should be looking at change from baseline or a spread in the patients who did well in two arms. This concept is not just an issue that I have, but something larger in the medical literature. In fact, this psychology journal has actually banned p-values because of the flawed system of null hypothesis testing. And I'll just read a quote here. This is from over 60 years ago from William Roseboom. In relation to p-values, he says in the bottom right here, surely the most boneheadedly misguided procedure ever institutionalized in the rote training of science students. P-values are too simplistic, too driven by sample size, too reliant on the null hypothesis, too interpretive, silent in effect size, and clinical relevance. Okay, so what are the alternatives? Well, instead, we need to report, we have to do some analysis, and we need to explain what we are doing. For instance, using graphical displays for data and descriptive statistics. So many wonderful programs that can help us better think how to display our reasonably raw data for our readers and for ultimately clinical decision making. We need to report measures of variation and measures of central tendency. And then we need to use and have thoughtful interpretation of our effect sizes. Another issue that comes up in the literature is using overly complicated statistics, which lead to arbitrary and ambiguous outcomes. And a classic example of this is the inferiority trial design, which was, if it was up to me, would no longer be used. And I'm not alone. I'll just give you an example here. When you set up an inferiority trial design, these are the possible outcomes: A, B, C, D, E, F, G, and H. Okay, so imagine setting up a multi-million-dollar clinical trial and then ending up with inconclusive, inconclusive, inconclusive as possible outcomes. And we've actually had some recent experience in our literature where this exact thing has happened. I sometimes joke or ask our trainees to explain all these different outcomes. And my experience is that all of the outcomes, with the exception of perhaps superior and inferior, are very difficult to explain both in the literature and also verbally. And it's just a great time to go get some popcorn. The crux of the issue here is this inferiority margin that is built into inferior design. So in our classic statistical testing, we already have our type 1 error, which is arbitrary, our type 2 error, which is arbitrary. And now we add another layer, which is this nebulous concept of an inferiority margin. And this will really drive the power and ultimately the outcomes. And again, there's usually no good precedent to come up with this inferiority margin. When you have this inferior margin, that's what begets all of these new different possibilities from the test. When ultimately all we want to know from a clinical trial is one better? Is it the same? And yes, if it's the same, we got to make sure that we know it's the same and it's not just underpowered, which is a common issue, I recognize. Or is it worse? I don't think we want to try to do anything more of that. It's hard enough to determine these outcomes without adding further layers of unnecessary complexity. Okay, so it's very easy to sit on the sidelines and nitpick. We've looked at some of the problems. Let's talk a little bit more about the solutions. We have better outcome measures than mean IOP. They exist, and the guidelines actually advocate for their use, not unlike the World Glaucoma Association guidelines, which I think are pretty good. Let's look at TRAB, or even let's just say BLEB efficacy. How do we evaluate? Well, I'd pose these are the questions for defining surgical success. First, can it be measured? 2, does it separate successful from unsuccessful patients? 3, does the patient care? And 4, would the patient understand? Well, let's look at eye pressure. Let's look at target eye pressures over time. This is from AEGIS. Many years ago now, over 20 years ago, it was shown that if patients consistently have an eye pressure in a reasonable target, in this case 17 or less, they did not have visual field worsening, as opposed to the other 3 groups where are clearly separated from the group that did well. So we can obviously measure eye pressure. We can separate the patients, at least from this study. Does the patient care? I'm going to put a little bit of asterisks in that. And when the patient understand, yeah, I'd like to think the patients understand eye pressures. And it is a reasonable surrogate by and large. So let's talk about number 3. Does the patient really care? Well, yes and no. I also want to remember, let's just say it's complicated. I want to remind us all that really what the patient cares about is things that impact their day-to-day life. And we've looked at this a little bit, and I'd recommend always having these measures as part of our analyses. So for instance, patients want to know the time to intervention, or if they're going to have another intervention. And we can display this in clinically meaningful ways, particularly using Kaplan-Meier curves and survival analysis. They want to know if they're going to get their vision back. Again, we can measure that too. Astigmatism was one of the drivers. This is something we can measure, looking at the surgically induced astigmatism, for instance, of a microstent versus a trabeculectomy. Okay, so let's look at a recent example. And this is the RCT comparing the ab-external microshunt versus trabeculectomy. Sentinel work, 2-year randomized multi-center study. Let's first look at the primary outcome. A 20% reduction in mean diurnal IOP from baseline with no medication washout without increasing medications. Has this ever been the goal for blood-based surgery? If not, then why are we using it as our primary outcome for a sentinel resource-intensive trial? Many of these patients had a baseline medicated eye pressure of 15. At that point, is a 20% reduction actually the goal? For instance, in contrast to, say, a patient who could have had a pressure of 30 on 4 medications and then left with a 20% reduction on 4 medications. Was that really the goal as well? Back to the medications. After blood-based surgery, the goal is to either eliminate or significantly reduce the medications. Yet here we are with this primary outcome. Let's look at some of the analysis. Now, it's hard when you start on the wrong foot with the wrong primary outcome, but I do like some of the analysis here. But I just want to point out that the different perspectives need to look at different aspects of this data. So a regulator, I think the question should be, does this do something? So we just need to look at the one arm of the microshunt, where we do see that many patients had met the primary outcome. Again, we can argue whether that was right or not. And you can see here over time that many patients continue to have success. Of course, it's different for the reimburser, the clinician, and the patient, where we want to look at the comparative arm. And that's where I'm really grateful that we have this opportunity and that this company chose to go this route. Okay, so we've talked a fair amount about efficacy. Now let's talk on the safety side. And I am definitely guilty of presenting tables and tables of safety data that is very complicated and hard for the readers to understand. And of course, when you have low sample sizes, lo and behold, your p-values are always negative, and you can just say there's no difference in safety. I think we need to do better, and I'm really impressed with this recent short article in the American Journal of Ophthalmology, where they tried to add some clinical context and relevance to the TVT 5-year safety data. So you can see what they did here on the left is they put down the proportion of patients who had various complications in each of the arms. Again, is this complicated? Well, fair enough. It's maybe not the simplest thing we've looked at. On the other hand, we look at OCTs all day, and I would argue they're much more complicated than that. But eventually, we get some pattern recognition. And I think this is the model that we need to be looking at going forward for all of our surgical reporting. So on the right, then they use a risk difference, and they give us a measure of variability, i.e. the 95% confidence interval, and they rank them for us in terms of the relative risk difference for the trabeculectomy and the tube arm. And I really like, again, how this has been laid out. Now, the one shortcoming of this is that not all safety outcomes are alike. We are much more worried about, say, hypotony maculopathy than we are about a little bit of extra iritis. And that's what they've done here. So they used the Delphi process where they asked experts what they thought the most devastating complications were, and they ranked all of these complications. And then they put the ones that are most devastating on the top and least devastating on the bottom. And then they also varied the width of these two bars by the incidence of these complications. So you can kind of get a relative sense of the two arms of which ones had more worrisome complications and also the relative prevalence in the two groups. So in summary, patient outcomes should drive reporting, analysis, and interpretation. We need to de-emphasize complicated statistical analysis masquerading as clinical significance. Observational studies are for exploration, data tracking, and safety. RCTs do help us on the efficacy. The interventional arm, I think, is most important for the approval. For the comparison and clinical decision-making and reimbursement is important. Big data, observational for safety, and then careful reporting afterwards. Thank you very much for listening.